Hi guys, it's Bill. I'm going to do a video review of what we talked about this week in diagnostic imaging. It was interesting responses that everyone posted, and once again, some great discussion. We talked about a theoretical family member calling and asking you about their back pain, in particular in relation to their imaging, their MRI, which they had. On the MRI, it was a degenerative disc disease. Pretty common scenario either with your family members or your own patients or colleagues. Back pain is very, very common. They say it's over 80% lifetime prevalence. So just about everybody gets back pain, and it tends to be over medicalized. I mean, the back pain, because it's so common, it's almost like having a headache or a cold or something like that would be the best way to kind of describe it. Not to minimize it. I mean, it certainly can be painful and disabling. Definitely have had some bouts of back pain myself, so I know exactly what people kind of tend to go through. But one of the things that we know in this country in particular is that we've kind of made a mess of back pain in terms of how much money we spend on it with imaging, now opioid medications, injections, and surgery. There's a great deal of overutilization for a problem that is relatively common, and in the majority of folks is a relatively benign condition, meaning that there's no serious structural harm or disease related to the back. It's probably less than 1% is related to a red flag condition, and probably less than 5% is due to things like a radiculopathy. So the majority of people with back pain have what they consider non-specific musculoskeletal back pain. And the imaging just tends to make things worse. So the guidelines would say you really shouldn't image anybody in the acute phase anyways, unless there's signs of red flags. So our patient in this case, it was not appropriate to get imaging because it was just adding to his anxiety and concern. So pretty common for people to hurt their backs and then get worried about it, and then maybe start freaking out over it, stop doing things, listen to bad advice. If you Google back pain on the internet, there's a million different things out there that are supposed to help it, or a million different causes. So it can be pretty scary for people if they don't get accurate information. So that was kind of the scenario in that I presented to you guys, and I think everybody was on board with, all right, let's try to minimize the structural imaging findings with this patient, get him moving, hopefully get him to PT. And I don't need to tell you guys this patient would do better if he went to PT first instead of his doctor to get some advice on getting moving and some reassurance. We also talked online about the language we use with our patients, and a few of you guys mentioned maybe using the term, normal wear and tear related to your back, and I would even be careful using that term, because wear and tear suggests like your spine's wearing out. It's like, an old shock absorber that needs to be replaced or something like that. So you just have to be careful with the language we use. There's some qualitative studies out there that ask patients about different terms, such as wear and tear and others, and many times it can be misinterpreted by the patient to mean something pretty threatening or fearful. So I would be careful with that. And we also talked about, using the term on imaging of degenerative disc disease makes it sound like you have a disease in your spine, which is really just normal aging of your spine. Similar to wrinkles on the skin, gray hairs, or losing your hair. We tend to see those changes on imaging. So we just have to be careful with that. In some patients, I will really try to steer their beliefs around that. Others that cling on to those diagnostic imaging findings, if they've had an MRI, sometimes it can backfire on you if you go in too hot and heavy and say, oh, don't worry about your imaging, particularly if they believe or have been told that this is a major source of their problem. So we do need to be careful with that we're gentle with patients and try to gently steer them around that. And that's not to say that not all imaging findings are not relevant. So, for example, if you have a fracture, a tumor, maybe a large disc prolapse with radiculopathy that correlates on imaging, these are all things that we would consider relevant. degenerative changes, facet joint changes, those kinds of things are really hard to tell how relevant they are because they're so common in the general population without back pain, up to over 50%, if not more, particularly once you get over the age of 30. So great discussion, and really, one of our roles as PTs is to hopefully keep patients away from this kind of stuff. And I think if, one of the things I'm trying to do with this class is, help you to educate your patients, colleagues, even if you're not seeing a lot of folks with back pain, it's still useful because this is so common. So great job again this week, guys. I'm also going to place a video about back pain by this guy from Australia, a physical therapist, Peter O'Sullivan. I'm going to place it also in your course documents. I recommend you watch it. It's really an empowering video, and it sort of speaks to some of the problems with back pain and some of the solutions for it. So hopefully you enjoy that. And I'll look forward to our discussions this week where we sort of switch gears and start talking about patients with more neurological injuries, in particular head injuries.